Hello viewers, good evening and I welcome you all on behalf of Indian Medical College to this online class. Dear viewers, in today's session we have a great speaker, our beloved Dr. Joseph Philipraj sir, who will be taking a class on the topic Ulcer, a clinical presentation in exam window. And sir is a professor from Department of Urology from Mahatma Gandhi Medical College, Pondicherry. He is having years of experience in his field and good evening and I welcome you, sir. It is our immense pleasure to have you here with us.
Yeah. Thank you.
Thank you, sir. So, viewers, in today's we'll be discussing about the ulcer. So, you have any clarifications or queries regarding today's session, please post them in the comment section below, and our doctor will clarify them at the end of the session. Sir, I request you to kindly start the presentation. Sir. Thank you.
Yeah, thank you. Am I audible?
Yes, sir. You're audible, sir.
Okay, fine. Good evening, dear students. I'm sure you must be having hard time trying to keep up with the studies, learning online, and all this exercise will make you better prepared for the examinations. Now, one of the common cases given in the clinical examination is the ulcer, examination of an ulcer. Now, basically, you must know what all the things to be presented during a clinical case discussion and how to examine an ulcer. Now, ulcer is defined as break in the epithelial continuity. It can be external skin or it can be in the mucous membrane like peptic ulcer disease. Now, ulcers can also be classified as non-specific, specific, and among the specific, malignant ulcers. So basically, ulcers are non-specific and specific, and ulcer is a break in the epithelial continuity. It can be skin ulcer or it can be mucosal ulcer. Now, evaluation of an ulcer. When they ask in the examination, what are the things you got to look into? First important thing in an evaluation of an ulcer is the history. Today we'll be talking about examination of a peripheral ulcer like leg ulcer. Now, history, how it started, how long it has been there, whether there is any discharge from the ulcer and any treatment was given, is it progressing? All this history should be asked for. Sometimes it can start as a swelling which bursts open and it becomes an ulcer, or it can become an ulcer because of trauma, or it can become infected injury and it becomes an ulcer. So history, how it started, how it is progressing, is there any discharge from the ulcer, does the patient have any comorbid factors like hypertension, diabetes, ischemic heart disease, and previous history of any other ulcer in any other limb, whether the patient had history of varicose veins, any treatment was given, or patient had history of long-term smoking and which has caused the ulcer now. That happens in thromboangiitis obliterans or arterial ulcer. Now you got to do is to examine the ulcer particularly. After that, you have to examine the surrounding of the ulcer, how the skin looks, whether it is looking healthy or it is shiny, thinned out, are there any distended veins around, all this you got to. Then in general, you got to examine for vascular insufficiency. Now, vascular insufficiency means arterial and venous. Now, arterial examination is by examination of peripheral pulses. So if it is leg ulcer, you have to feel the dorsalis pedis and posterior tibial artery. Then proximally, you will go ahead popliteal and femoral artery. So arterial pulsations you must feel for and then see whether there is any decrease. Normally in thromboangiitis or obliterans, there will be absence of these peripheral pulses. In atherosclerotic disease, there will be absence of peripheral pulses. After the arterial examination, you have to examine the venous system also. Now, venous system, you got to look at the any distended veins are there. Are these veins extending up to the groin of the individual, or are they thrombosed? Whether there is peripheral edema of the skin, which is pitting, or it is non-pitting edema, or there is any discharge from the ulcer. Then last but not the least is the examination of the peripheral nerves. You got to look for sensation, the soft touch, pain, and all these peripheral sensations should be looked into to rule out any lesion of the nerves. It can be either due to nerve injury, or it can be diseases which can give rise to lack of sensation or decrease in sensation. The commonest amongst them is the diabetes mellitus. And India being the capital of diabetes, so you will find a lot of these patients who are long-term diabetics, not controlled properly, will have peripheral neuropathy or loss of sensation, which can give rise to ulcers, usually in the pressure areas. Another lesion in our country which we are seeing is the leprosy, where there is nerve lesions which can manifest. Then another thing is spinal cord injury. Patients are paraplegic, and these patients can have what is known as trophic ulcers or pressure ulcer. So you must know the history of the ulcer, examine the ulcer in detail, look for arterial and venous insufficiency, and then look for nerve lesions or sensation in the peripheral limb. Now, history of the ulcer. What are the things you got to look for? Mode of onset, precipitating event. That means either an injury can predispose for this ulcer, or it can start as a swelling and which has ruptured and become an ulcer. Now, long-standing ulcers, patient who has received radiotherapy, they can develop ulcer, which are known as radiation ulceration. Now, so how it started, was there any injury? Is there any superadded infection? And the patient had long history of smoking or venous insufficiency like varicose ulcer or swelling of the calf muscle due to deep venous thrombosis. And the ulcer, how long it has been there? Is it remaining the same size, or it is progressing? And if it is progressing, is the size increasing, and other symptoms along with that? Does it patient realize that there is pain? If there is no pain, usually it is due to trophic ulcers, and in case of neoplastic ulcers, and in case of ulcers due to leprosy. But usually infective ulcers, traumatic ulcer, venous ulcer, arterial ulcer, they have pain until the nerves get fully damaged. Then there may not be pain at all. In diabetes, what happens is they will have peripheral neuropathy. Patient will not realize the injury, which gets infected because of the increased glucose in the circulating blood, and then there will be progress of this ulcer and infection. Now, the infection can spread above or into the deeper tissues, and it can involve even the tendons and even bony structure. Now, systemic factors, like I mentioned, diabetes is an important thing. You must ask for the history of diabetes, then hypertension, ischemic heart disease, or venous insufficiency like varicose veins, deep venous thrombosis, history of long-standing smoking because of TAO. All these systemic factors should be elicited from the risk factors, like patient or some individual who is having this job of standing for a long hours, they are more prone to develop varicose veins, which can progress further if it is not taken care, and then it will lead to complications of varicose veins. Now, peripheral ischemic symptoms, whether patient noticed any pain in the limb. Usually in the metatarsal region, they will have pain, which is gradually progressing. Initially, it will start after walking quite a distance. But then if the ischemia increases, that means the lumen of the artery gets obstructed complete gradually, then the distance also reduces and the pain manifests early, and this is known as claudication distance. And the last thing is when patient even sitting, they will have pain, and this is known as rest pain. And if you see that rest pain is due to crying of the dying nerves, that is what the books mention, and you must know all this. Now, previous interventions like application of any medications, or see in the villages, they will apply all medications, some vague things where the quacks have made, and all this will precipitate the increase of ulcer infection also. Now, interventions can be whether they had undergone, like in arterial ulcer, whether they had undergone sympathectomy, lumbar sympathectomy, or any other procedure on the arteries to improve the circulation. And in varicose veins, whether they have undergone any surgery, whether they had any treatment for deep venous thrombosis, all these should be taken in the history about treatment of this ulcer. Whether they have received any antibiotics, is there any discharge, or it is purulent discharge, smelling bad, all these things should be elicited in the history of the ulcer. Now, to remember the causes of ulcer, there is a mnemonic: vein, pain, venous. VAIN, PAINV, nus. So, vein pain, that is the mnemonic to remember the causes of peripheral or limb ulcer. V stands for venous, A stands for arterial, I stands for infection, like it can be specific or non-specific ulcer. Then N stands for neuropathic, that is vein, VAIN. Now, pain is pressure source. P is pressure source, like trophic ulcers. Spinal cord injury, patient has peripheral nerve lesion, and leprosy, they are all due to pressure source. Then PAIN, A is for arthritis, usually rheumatoid arthritis or polyarthritis nodosa, where there is pressures over the metatarsal because of the deformity, and they end up developing ulcers. I is due to injury, N is malignant or neoplastic ulcer. So simple mnemonic to remember types of ulcer is vein pain. So vein is venous, arterial, infection, neuropathic, and pain is pressure source, arthritis, injury, neoplastic. I hope, when we were students, I used to remember with mnemonic because, we were not that brilliant students or anything to remember. So this used to make us remember the things easily. So etiology or causes of ulcer is vein pain, VAIN, PAIN. Now, examination of the ulcer. Here also there is a mnemonic, BBEDDS, BBEDDS, BBEDDS. So B stands, first B is for site, size, shape of the ulcer. Next B is for base of the ulcer, whether it is red, pink, white, black. We will discuss that in detail. E is for edge of the ulcers. Then D is for depth. How deep is the ulcer? Is it only superficial, or it is gone deep into the tendons and even involving the bone? And then other D is discharge, whether there is serous discharge which is clear, or it is purulent, or it is bloody. Usually bloody discharge is seen in infection as well as malignancy. And S is surrounding, skin changes, color of the skin, edema of the skin, distended veins, whether there are any healed scars previously. So the examination of the ulcer, the mnemonic to remember is BBEDDS, BBEDDS, BBEDDS. So I hope you guys can remember it easily by this basic mnemonic: BBEDDS, basics, base, edge, depth, discharge, and surroundings. Now, examination of an ulcer, you must remember all these points. So when you talk like examination, you cannot say the site of the ulcer is on the thing. So you must be able to talk freely, continuously. There is a ulcer, whether how many are there, single or there are multiple ulcer, where it is exactly situated. Now, site is an important thing. Depending on what type of an ulcer, usually the site is made out. In venous ulcers, it is over the medial malleolus, or what is known as the gaiter area. Arterial ulcers are usually seen over the metatarsal heads. Trophic ulcers are overseen over the pressured. And due to rheumatoid arthritis, because of the deformity, heads of the metatarsals are the site for the ulcer. Now, shape of the ulcer. Usually, the ulcer shape, it can be oval or circular or elongated or irregular shape. And size, you got to measure them in centimeters, both in two directions, vertical as well as horizontal. And then you must say that in relation to a bony point. You can say an ulcer situated on the medial aspect of the left leg, which is in size about 5 centimeters above the medial malleolus. So the examiner will definitely know what exactly you are talking about, and he can picturize or conceptualize the findings, what you are mentioning. Now, floor of the ulcer. Now, floor of the ulcer is what you see, and base of the ulcer is what you feel. So floor is usually, if it is a healing ulcer, it is like healthy granulation, reddish, which looks like. If it is infected, there will be yellow slough or discharge. If it is not healthy, then you will find dead tissues in the floor of the ulcer. Edge of the ulcer and the base is what you feel, whether it is situated over the tendons or over the bones. Then tissues, skin around the thing, and deeper structure. You must move the limb and see which muscle is attached to the ulcer, is attached to, or it is free. And after all these examinations, you must look at the drainage area of the limb. For the limb, it is the groin or the inguinal lymph nodes you must look for. Sometimes if it is posterior on the leg, look at the popliteal lymph nodes also. But you must look for the groin or inguinal lymph nodes, whether they are increased in number, they are bigger in size, and they are tender. Sometimes when there is infection, lymphadenitis, it can be tender. So this is how you have to examine the ulcer. Now we will discuss each thing in detail. Now this is the diagrammatic representation of an ulcer. Now look at this. This is the ulcer. Now the floor is what you see. Base is what you feel. Now, margin of an ulcer is junction between the normal epithelium and the ulcer, right? And edge is area between the margin and the floor of the ulcer. So edge is area between the margin and the floor of the ulcer. Margin is junction between normal epithelium and the ulcer. Floor is what you see, base is what you feel. Is that clear? So this is basic representation of an ulcer. Floor, you must realize, is what is seen, healthy granulation or unhealthy tissue, necrotic tissue is there, slough is there. Base is whether it's tendon or it is muscle or it is the bones. So margin is between normal epithelium and the ulcer. Edge is between margin and the floor. So please remember this difference between, so that you will be able to examine the ulcer better. Is that clear? So ulcer, it is the ulcer which is situated over deep tissues. Now there is discontinuity of epithelium, and that is the ulcer. The parts of the ulcers are floor of the ulcer, base of the ulcer. Floor is what you see, base is what you feel. Now regarding the margin, margin is between ulcer and the normal epithelium. Edge is between margin and the floor. So is that clear? You must be very clear about this and ensure that you will be able to examine and tell the difference between margin, edge, floor, base. This is what they will ask in undergraduate examination, these subtle differences which you should be able to make out and tell them very clearly. Now, ulcers. Now, edge of the ulcer. Edge is, like we said, it is between margin and the floor. Now, type of the edges. Each one is specific. Some are given specific name. And the short form or the mnemonic to remember is PUREF. P-U-R-E-F. PUREF. P stands for punched out. Usually punched out ulcers are trophic or arterial ulcers, but in arterial there will be pain, whereas in trophic ulcer or neuropathic there won't be pain. That is the differentiating feature between a trophic ulcer or neuropathic ulcer and arterial. In arterial there is pain, in trophic or neuropathic there is no pain. So the mnemonic is PUREF, P-U-R-E-F, the types of edges. P is for punched out. Next, U is for undermined. Classically described for tuberculosis. And even in pressure ulcers, it can be. But in our endemic setup and in our country, if they say it's an undermined edge, you must think of tuberculosis until proved otherwise. So you must remember, punched out is usually trophic, syphilitic ulcer, gummatous ulcer, arterial ulcer, and neuropathic ulcers. Undermined is usually tuberculosis, other can be pressure. Now rolled edges. Usually it happens in basal cell carcinoma. Usually they are seen in the face of the individual. Then edges are everted. This is proliferating growth and classically described for squamous cell carcinoma. Especially in our country, you will find a lot of these patients with penile cancer, penile ulcerous growth. They are classically described as everted edges. Then venous ulcers are flat and sloping. So the mnemonic to remember the edge of the ulcer is PUREF. P-U-R-E-F. P stands for punched out, undermined, rolled, everted, flat or sloping. Is that clear? You must be very clear. Punched out is trophic ulcer, arterial ulcer. In arterial, there will be pain, whereas in trophic ulcer, there won't be pain. Undermined, classically described for tuberculosis, whereas rolled, it is for basal cell carcinoma, usually seen in the facial region. Everted is classical for skin ulcers, skin cancers, penile cancer, where it is edges are everted. Flat and sloping you will find in venous ulcer or ulcers due to venous insufficiency. This is basically about the edges of the ulcer. Now you see the ulcer. It is situated on the medial aspect of the leg. And you see this is the normal epithelium, this is the ulcer. So this is the margin. From the margin to the floor, this is the edge. Now this has lot of slough, yellowish dead tissue, blackish tissue. This is not a healthy ulcer. The floor is made up of slough, yellowish slough and even blackish. And this blackish color indicates it is a dead tissue. Normally, if it is a healthy ulcer, you will find different. Now you see this is also, so there is, you can describe it as an ulcer, there is discontinuity, or there are two ulcers on the medial aspect of the leg. One is vertical dimension, other one is horizontal in the maximum diameter from the medial malleolus or the bony landmark or tibial tuberosity below. So that is how you are going to mention. And you see the size, it is from here about 6.5 to 17. That means it is around 11.5. Okay, so this is the thing, how you measure the ulcer. And this is the floor, this is the margin, this is the edge, this is the floor. Base is what you feel, and you wear a glove and examine this patient. Now you see, this is also a non-healthy ulcer. See that it is round, circular shape, margin, then skin surrounding is shiny, not looking healthy, and scaly. Floor, you see that it is made up of necrotic tissue, discharge is seen. See the serous discharge coming out? This is typical of infective ulcer or ulcer which has got infected. Now, granulation tissue, they will ask you what is granulation tissue. It is a new connective tissue with developing microscopic blood vessels. This is due to healing process, and this forms on the surface of the wound during healing. If there are no infection, no foreign body, and vascular supply is good, then the ulcer heals without much problem. Quite often you must have realized when you get injured or when you get hurt during playing, the ulcer heals after few days because there is no compromising factors or comorbid factors, and there is no superadded infection. Now, granulation tissue, it grows from the base of the wound because there is tissue there, vascularity is there, whereas floor and all are dead tissue. So from the base of the ulcer, this connective tissue, new connective tissue and microscopic blood vessel start forming, and this forms a granulation tissue. When the granulation tissue looks red like this, nice, this is a healthy granulation tissue. You can see that edges are also coming closer as the ulcer starts healing. It heals from the periphery. The granulation comes from the base of the ulcer. This is a healthy granulation tissue. Whereas this is not a healthy granulation tissue. You can see the white slough, necrotic tissue, surrounding skin is looking blanched, pale and shiny. So these are all the important things to make out in a ulcer. Now we will just discuss few types of ulcer. One is, like in the beginning we said, infective. Now infective can be bacterial, pyogenic, which can involve the bones. It becomes osteomyelitis, which can become ulcerated and discharging sinus because of osteomyelitis, or the infection can spread down and involve the bone secondarily. It can be tuberculosis, and usually tuberculous ulcer edge is undermined, whereas in syphilitis or gummatous ulcer edge is punched out. Now, tropical diseases, infections can give rise to, even fungal disease can also give rise to infection, especially in patients who are diabetics who can be susceptible for fungal infection. So these can be the causes of infective ulcer. Now, it can be due to exposure associated, there will be cellulitis surrounding, inflammation will be there. Patient can develop systemic symptoms like pain, fever. So all the symptoms can be present, and because of infection, there will be exudates. Then usually infective ulcer keep increasing in size. The discharge can be foul smelling and greenish in color. Now, traumatic usually happens in radiation, burns, thermal burns, bites, and in decubitus ulcer, patient who is long-standing, lying down on the back pressure over the sacral area or over the posterior heel. All these patients, they can develop decubitus or pressure ulcer. Neoplasia can be due to melanoma, squamous cell carcinoma, basal cell carcinoma, and specific connective tissue sarcoma in patients with HIV infection, Kaposi's sarcoma. So these are all neoplastic. Melanoma, squamous cell carcinoma, basal cell usually seen in the face region, and Kaposi's sarcoma usually seen patient with infection due to HIV. Now, neoplastic ulcer, when will you suspect? When the ulcer is not healing. Whether the patient had previous malignancy and risk, like usually a long-standing ulcer. Then there is something called Kangri ulcer. In patients in Kashmir where there is cold, they keep this hot earthen pot over the belly. And this can give rise to ulcer, and long-standing this ulcer can become squamous cell carcinoma. And another thing is known as dhoti ulcer, where they tie the dhoti very tight, and this chronic inflammation, infection, and this skin becomes ulcerated, and it can become malignant squamous cell carcinoma. Exposure to radiation or chemicals, ultraviolet radiation, ionizing radiation, all this can give rise to skin changes which can become malignant. Now, little more in detail about the venous ulcer. Venous ulcers are due to ulcers developing in the leg, usually in the leg due to chronic venous insufficiency. That means the veins or the venous system is not functioning properly. Ulcers can be due to varicose veins, deep venous thrombosis or thrombophlebitis, previous ulceration, previous treatments, sclerotic changes, edema, and these ulcers are painless. It can be due to, like I said, occupation. When they stand longer, like teachers, postman, they stand longer, the veins can become, or it can be due to congenital abnormalities of this. So usually along with this venous ulcer, peripheral vascular disease can be existing, diabetes and rheumatoid arthritis. Now this is briefly, when do you call it as venous insufficiency chronic? Usually ulcer is called chronic ulcer when it is present for more than 6 months. If it is not healing for 6 months and more, it is called as chronic ulcer. Now the lower limb venous system is dependent on the great saphenous vein, which is the superficial system, which opens in the saphenous opening and joins the femoral vein. On the posterior aspect, you will see the small, from the lateral aspect, the small saphenous vein, which enters the popliteal vein. So the great, which starts on the medial side, next to the medial malleolus, and ascends along the medial side of the thigh and joins the femoral vein in the saphenous opening. The short saphenous system starts on the lateral aspect of the foot, and it travels upward and opens into the popliteal vein in the popliteal fossa. Normal flow of the vein, the blood flow is from below upwards towards the heart. Now, there are valves in these veins which prevent retrograde flow of the blood. That means the blood flow won't come backwards. It is always unidirectional. Now, when the valves are incompetent, or if there is any pressure, then the flow can be, stasis can be there, or retrograde flow can happen. Now, from the superficial system, the deep veins are connected through perforator veins. Now, these are named perforators and specific, some are unnamed, and these veins from the superficial blood flows goes into the deep system. From the deep system, because of the peripheral heart, what we call this calf muscles, there is peripheral pump which pumps the blood towards the heart to go into the femoral vein and into the iliac vein. So this is how the basic venous system works. It is from below upwards, superficial to deep, there is no retrograde flow. But when there is problem, valves are incompetent, there is pressure in the abdomen, over the veins, all these start distending. Or the deep venous system gets thrombosed, peripheral, superficial system becomes distended. Dilated tortuous veins, they are known as varicose veins. So this is basically venous anatomy to understand why the ulcers happen. Now, usually seen in this area next to the medial malleolus, and this is known as gaiter area, commonest site. It can be over the lateral malleolus 20%. It can involve the circumferential over the leg. So this is the commonest site. Gaiter area can spread upwards also. So venous ulcers are commonly seen here in the gaiter area. Now these ulcers can be small or large, shallow, vertically oval like this. And margins are irregular, edge is sloping, and floor granulation tissue, depending on whether it is healing or not healing, healthy or unhealthy granulation tissue. Venous is sloping edge. Margins are irregular. Margin is junction between normal epithelium and the ulcer. It can be large, it can be small, vertically oval. Now, venous ulcer base, usually it is not fixed to the deep structures. If it penetrates deeper, then it can get attached to the deep structure. There won't be induration, usually soft. But if there is induration, that means there is involvement of deeper structure. And it is depth, it is shallow ulcer, it is not extending deep like malignant ulcer or even in trophic ulcers. Discharge will be usually serous. Occasionally it can become purulent because of infection, greenish because of infection, and it can be bloody because of granulation tissue. Usually, initially it will be painful, gradually it can become painless. Surrounding skin will be edematous, shiny, there will be eczema, pigmentation, all these are all changes of venous insufficiency. And there can be distended veins above, which is varicose veins. Now see, chronic venous ulcer is one which has been there for longer than 6 months, and it is due to chronic venous insufficiency. Chronic venous insufficiency is due to venous problem, and they develop irreversible skin damage as a result of hypertension, because the vein columns stagnate, there is no flow from below upward, there is venous hypertension. You see this leg, it is more like inverted champagne bottle appearance. It is usually seen in deep venous thrombosis. There is eczema, there is pigmentation, there is shiny skin, loss of skin appendages like hair and all will be there. And this can lead to ulceration, and that is known as chronic venous ulceration. There is break in the skin. Chronic is more than 6 months. Usually medial side over the malleolus, greater area, or it can be tibial tuberosity. So this is, you must understand, chronic venous insufficiency means there is loss of functioning of the venous system properly and the stasis of the blood. There is increased blood column in the veins, which causes venous hypertension. There will be exudation from the veins. The hemosiderin pigment enters into the skin surrounding, causes inflammatory reaction, skin becomes pigmented, and there will be edema, and even skin becomes scaly. In the end, they lose their skin appendages like sweat gland, hair follicle, all this will disappear because of chronic venous insufficiency. Now, this is one of the type of chronic venous insufficiency. This is stage 1, and it is over the medial malleolus, and this is known as malleolar flare. So malleolar flare means there are, like, spidery type of veins which are seen over the medial malleolus. And this is, in the initial stages. Then you have the atrophic blanchie. Atrophic blanchie is whitish scar-like skin is seen, hypopigmented, hyperpigmented area, skin, there will be lipodermatosclerosis, and this is known as atrophic blanchie. This is malleolar flare, and this is atrophic blanchie. And the last stage is the ulcer. You see that how the limb looks edematous, swollen. There is pigmentation, hyperpigmentation, circular ulcers just above the medial malleolus, gaiter area, chronic peripheral edema is seen, loss of hair. See here, there is hair, whereas this is not there. And all these are changes due to chronic venous insufficiency, venous hypertension, and the last stage, early stage is malleolar flare, atrophic blanchie, which progresses to venous ulcer. Now, there is classification of this venous insufficiency. It is based on CEAP, CEAP classification. C is clinical appearance on the leg, malleolar flare, atrophic blanchie, or ulcer. Etiology, it can be primary varicose veins, or it can be due to secondary to deep venous thrombosis or any abdominal malignancy. It can involve superficial veins, deep veins, or perforating veins. P is pathophysiological, whether there is deep venous obstruction, so the veins distant in the superficial system, that is due to obstruction. Or it can be saphenofemoral valve incompetence and reflux of blood. This is usually in varicose vein. So this is basic classification of venous insufficiency, CEAP, CEAP. C is clinical, etiological, anatomical, and pathophysiological. Now this is the thing. See, you can see normal no visible veins. There is reticular veins. Then you will have varicose veins. Then edema of the skin, pigmentation, eczema, lipodermatosclerosis, and healed wound or open wound. This is the clinical from C0 to C6. You just remember that malleolar flare, lipodermatosclerosis, and ulcer, and veins which are seen. So usually it is due to venous hypertension, and because of this stagnating the venous column, and that will cause all these changes. Now, treatment of this venous ulcer is to improve the blood flow in the legs. You have to treat these varicose veins and ask them to do exercises so that the calf muscles will function properly, and night times to elevate the limbs so that the edema will come down. There are some drugs which will help in preventing the reflux and venous stone. Nowadays, you have this endovenous laser ablation of the perforator veins so that the veins, there is no backflow from the deep to the superficial system. Previously, they used to use sclerotherapy of the perforator veins and the veins, but long-standing or better results are seen in surgery, which is the treatment for the varicose veins, that is Trendelenburg, stripping, ligation, and stripping. So this is basically management: improve the blood flow, elevate the limb, pressure stockings, and the exercises to walk on the tip of the toe to increase the calf muscle pressure so that the venous flow is improved. Drugs can be given to improve. And if all these fail, then surgery is the only ultimate answer. I hope you have understood the basic examination of an ulcer and specifically venous ulcer. What are the types of ulcers which can happen? In the next class, we will talk about arterial ulcer and examination of arterial system. Happy learning. I hope it is clear. Any doubts, please mail me. I will be willing to answer to the best of my ability. Thank you.
Thank you so much, sir, for such a wonderful session. So students, I hope you have enjoyed the session, and you can also spread a word to your friends regarding the Indian Medical College and the sessions taken in the online. So this is our YouTube channel and our Facebook page. And thank you for such an informative session, sir.
Yeah.
Students, if you have any other queries, you can just post them in the comment section, live streaming in the YouTube, and sir will clarify them. So you can also access the recorded videos of the sessions, MCQs, announcement of all the session will be made at our Facebook page. So, sir, as we don't have any queries from the audience, we shall wind up with the session, sir.
Okay. Yeah. Thank you.
Thank you so much, sir. Thank you so much.
Yeah.
Thank you, students. Hope you'll see you in the next session. Stay tuned and subscribe to our channel.